Yes, yes. We will start inshallah after 2 minutes.
ما تحتاجون انتي وريما عشان نبدا. يلا الحين. كذا بتدخل الناس. باي.
Bismillahirrahmanirrahim. Dear distinguished attendees, Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of Arfa Society and its board of directors, we would like to welcome you and thank you all for joining us tonight. I'm very pleased to meet you today with a series of scientific lectures on the sideline of the first interactive multiple sclerosis exhibition in the Middle East and Kingdom of Saudi Arabia. Tonight, we will listen to an elite group of speakers in multiple sclerosis field to tell us about the latest update in diagnosis, treatment, and post-diagnosed palliative care. Dear audience, our first speaker, Dr. Ibtisam Athbeti, a neurologist and neuroimmunology consultant, MS specialist in King Fahd Military Medical Complex, Tehran, Saudi Arabia, a chairwoman of joining the local training committee in Eastern Bloc, Saudi Arabia. She did her training between University of British Columbia, Royal College, United Kingdom, and finishing her journey with Copenhagen, Denmark. Her talk entitled on a new criteria of multiple sclerosis, diagnosis criteria of 2024. Dr. Athbeti, floor is yours, please.
Assalamu alaikum jami'an. Good evening. Thank you for coming at this time, and thanks for AFA for sponsoring this and for the invitation from our colleagues, Dr. Fawzia, who we are missing here today. The topic that I'm going to present is about the multiple sclerosis new diagnostic criteria. It's a kind of a recent update, so we just actually presented. It's not yet published. in September, a few weeks ago, in the extremes. This is the groups who have joined several times to come up with the new updated criteria that we usually use. We know the 2017 criteria that we use for the diagnosis of multiple sclerosis, and this is the revised one that I'm going to talk about. There are a lot of things that have been added, so probably I will not be able to touch on everything. It might be a little bit different than the old one. The major differences are highlighted below. So there are new MRI signs that we look for, and they are not signs that are easy. You need a trained radiologist in that field in order to help you in getting these. We'll talk about it in a minute. There's a special highlight about a special entity, which is the radiologically isolated syndrome. And finally, the guidelines have added paraclinical tests or ancillary tests, namely the OCT, the 3-kappa chains in CSF. So the first one that I'm going to talk about, and later I will tell you what are the proposed diagnostic criteria, is the central vein sign. It's related to the earliest thing that we have learned in multiple sclerosis, in which there is perivenular inflammation that starts in the vein. This is the first thing that happens in multiple sclerosis, inflammation. And actually this inflammation, you can see it on MRI images. It's a technique that you need to do on 3 Tesla or 7 Tesla MRI, and so probably 1.5 Tesla would not be the best MRI. That's probably where the difficulty comes from. And then you have to lay over 2 different sequences, the T2 star on top of a susceptibility weighted image, and then the combination will lead you in seeing that central vein sign. I'm not sure the pointer is working or not. Probably it's working not on the slides, but you can see the arrowhead here. It's a black line, very small line that you see inside the lesion itself. You need to count them and see each lesion alone, so it needs a lot of dedication in order to confirm that. And you should have a threshold, so 1 is not enough. And after having this on different studies, there's probably a threshold of 6 and more will be highly specific and sensitive that what you are seeing is a demyelinating plaque of multiple sclerosis. And this is what I have mentioned. You can see there are a lot of inclusion and exclusion criteria. These central vein signs, we see it only in patients who have multiple sclerosis. It's good in differentiating between other white spots that we see it, and sometimes we can not differentiate between them, like white matter lesions for ischemic stroke or migraine. They don't have the central vein sign, and that's why it's highly sensitive and specific. The next one is the paramagnetic rim lesion, also or PERS. It is something that you see on MRI. It happens as a result of, again, related to the pathology of multiple sclerosis. On the rim of some of the MS plaques, not all of them, the chronic ones, you will have this hemozygoid deposition coming from the macrophages. And this can be illustrated on a special sequence, again, on MRI as a low intensity signal. And you should see it on 2 consecutive slides or slices in order to say that this is a curve. This is also highly sensitive and specific. You might not see it on all demyelinating plaque of MS, and if you see it on one lesion, that will be enough for you in order to reach a threshold of saying that this is a multiple sclerosis plaque. The OCT, I think you're all familiar with. This is something that is used frequently by our neuro-ophthalmology colleagues. It is very objective method, in which you have a clear retinal fiber layer, the red one there, and you can measure the thickness of the nerve retinal fiber layer after an attack of optic neuritis. Usually this happens after an acute attack of optic neuritis, so you can document this by the OCT. And finally is one of the most important things that we use in the diagnosis of multiple sclerosis, also mentioned in the 2017 criteria, which is the oligoclonal band. These are immunoglobulin that are present only in the CSF, a few number, but not present in the serum. And if you do that, then this confirms dissemination in time in the old criteria. However, the oligoclonal bands might be rate dependent, might be technically difficult, and now with the new criteria, it can be interchanged with something else, which are the kappa chain. So to simplify it, the immunoglobulin, usually you have an FC portion, the one in blue, and FAD portion, the one above. And we have a heavy chain and light chain. The heavy chain is the blue one, and the green one is the light chain. And they found that in patients with multiple sclerosis, B cells, the active B cells in the central nervous system, they also produce oligoclonal band plus free light chain. So you have the whole immunoglobulin, and in higher quantitation, you will have also the light chain or the kappa chain specifically. And this can be done by machine. There are two different machines that they can measure them, and it has been used in detecting light chain in other diseases like multiple myeloma. If you detect them, it is an objective method, and it is less expensive. And this can be, if you have the, I'm not sure if it's available here in the kingdom, there are special labs that they can provide it. If you have the privilege of sending that, this can equate for positive oligoclonal band in the central nervous system. So now we will talk about the criteria of the newly revised criteria. So we know that in what you use always, the traditional way of diagnosing MS, and you have the dissemination in space, meaning different areas of the brain, and in time, meaning on different times. So that's why it's a multiple sclerosis in different areas. The only thing that the previous criteria, 2007, we used to have only 4 topographical areas that are classical for MS, and you count them for the diagnosis for multiple sclerosis. The first one is the juxtacortical or cortical region. The second was the periventricular, which are the ovoid perpendicular to the ventricles. The brainstem region that are classical for MS. The spinal cord region, again, they should be classical for MS, not with other molecules. And the fifth one is added with the optic nerve, which is something that was not present in the 2017 criteria. And this you can confirm it by radiologically an MRI showing the signal change that's typical for the optic neuritis of MS, or by an OCT or visual evoked potential. So if you have this, that will count for one topographical area of multiple sclerosis. This is a new thing. And for that, you used to say, again, dissemination space and time, but with the new criteria, you can have the dissemination in space. If you have a positive oligoclonal band or the free kappa light chain, you have multiple sclerosis. But what about if you have, there are different scenarios. If you have a patient who has multiple sclerosis in 2 topographical areas or more, what do you need to have more in order to confirm the diagnosis of multiple sclerosis? You need to have one of the following only. If you have a positive CSF oligoclonal band or free kappa chain, 6 of the central venous line or 1 pearl, or dissemination in time, or there is a lesion at least in 4 out of these 5 lesions, then you have the diagnosis of MS. But if you have it in 1, then you need a little bit extra evidence of multiple sclerosis. You must have the IS6, CVS, or 1 pearl, plus dissemination in time, or you have a positive oligoclonal band. So you need to collect more evidence if you have it in only 1 topographical area that we used to count in the previous criteria of optic neuritis. Now we have the special entity in 10 to 15% of the patient when they have primary progressive MS. Now it is probably diagnosed primary progressive MS earlier. And you have at least 2 lesions of the spinal cord, plus you document dissemination in time, and that should be progressive over 1 year or more. Plus you will have a CSF positivity for oligoclonal or free kappa chain. So now this is a little bit different as well, and you have an earlier diagnosis of MS. And once you exclude all the other markers, it's very important that the history and the physical examination should be typical of an MS. You exclude other markers, and you apply the criteria, then you have a diagnosis of multiple sclerosis. So I think I talked about that, the importance of pearls and CBS. I think that will be done only in special centers. Maybe that may not be something that will be easy to implement, and I think only the future studies will show how much we can implement from these criteria in real life. And then these criteria, of course, are done in this way in order to increase their sensitivity and specificity. And it's very important that these new MRI things are good for diagnosis, but they are not mandatory. So if they are not present, but the other criteria are present, that would be enough. So if you could not do them, it's not, you still can diagnose MS patients. So they are optional in special situations. One of the situations that will be of help is that in a special group, the patients who are more than 50, they are prone to have risk factors like diabetes, hypertension, and then they will have white matter spots, and they're not sure if they are MS lesions or demyelinating plaques. And in this, it is advisable to have a more specific tests that will increase your specificity and make sure that these are demyelinating plaque of MS. And so it's advisable to either do the central venous sign or have CSF positivity for oligoclonal or the free kappa chains. What about pediatric population? Now, if the child is 12 years old or more, then he's probably will have MS more than children who are less than the age of 12. And in these cases, you need to have, again, a classical history of multiple sclerosis with the examination. But in special situation, you might test MOG. So some of the MOG or MOGAD can mimic multiple sclerosis, and only in special situation. They also highlighted that it should be done in a specific way using some assay that we call it cell-based assay, which is, again, this is one of the challenges that we face in our daily practice. It's only available in specific labs. The common lab that most of the hospitals in Saudi Arabia send for are not the cell-based assay, especially for MOG. Maybe in the future, these commercial labs will change their way of testing them. But if the child is less than 12 years of age, they advise to do MOG in almost all these patients in order to make sure that you're not dealing with MOGAD disease. Another thing, I think similar to the previous criteria in 2017, especially in children who are presenting with ADEM, you need to have a 19 days timeline or 3 months before a second attack happens in order to say that is typical for MS to say that the patient has multiple sclerosis. So this is to sum up. Again, this is a diagram that was presented in the extras. So if you have a patient who's typical, so again, they highlighted the importance that the initial workup, the history, and clinical examination, everything is suggestive of MS. You excluded all things, then you're in the right track. If you have 2 or more lesions, you can see here on the right side, then, and you're talking about relapsing genetic and multiple sclerosis, you probably need a little bit of evidence, either one of the following, the CSF positivity or the MRI, CBS or PERL, or dissemination time, or for and after the lesion you have MS, or if you have 2 lesions in the spinal cord progressing over a year or more, this is primary progressive MS, you need to have a positive CSF in this case. What about if you have it in one area? You need to have more evidence, so it's a must to have either the MRI, CBS, or PERL plus CSF, or plus dissemination in time. And if you're not dealing with MS, then there are a lot of red flags. Of course, time will not allow us to talk about everything. Then probably you cannot go to this part yet. You need to go and see what's the other differential diagnosis. Now, a special entity, I think we will be able to if you apply this, you will then treat a lot of RIS. RIS typically are MS demyelinating plasmas are incidental. When you take the history and do the examination, the patient has no clinical signs, normal neurological exam, and no history suggestive of multiple sclerosis. But when you do the MRI, the lesions are typical for MS. So they highlighted this very clearly in this new guidelines, and the reason for that is the majority of the patients will develop MS. And you can see that after 2 years, around 90, but when you go to 15 years, almost 70% have evolved from RIS to MS. And for that reason, they wanted to treat early and diagnose these patients early, and therefore we should reduce our threshold in diagnosing MS patients in this specific situation. So what are we have to diagnose patients with RIS, with MS? If you have dissemination in space and time, again, the same rule apply. How to confirm that? If you have dissemination space on the MRI or the topographical area that we talked about, plus a positive CSF, legal clonal band, or free kappa light chain. Or if you have space and you have 6 or more of the CVS, then you have MS. So now you can see probably a lot of patients that we used to follow up in the clinic, we're not sure whether to treat or not treat. Now with this new guidelines, will be labeled as multiple sclerosis. So again, this is just a summary. And to simplify it, you have to see just, you can see the last box here, that if this applies to the patients, you're sure that the demyelinating plaques are classical for multiple sclerosis, that you can do diagnose patients with MS even if they don't have any signs or symptoms. So to just give an example, a real-life example of how things have changed, or probably might change in the future, is that this is a patient that we have seen in the clinic. She's 36. She's having migraine, the usual migraine for a long time, 5 years. She had a CT scan initially that was normal, nothing was suspicious. So she was doing fine over the past 5 years, and then her migraine had changed. She came to the ER because nothing was helping, and for that she was admitted, and an MRI was done to investigate why the headache is different, and we had these lesions. And when we examined her, her neurological examination is normal. And so you can see, for the sake of time, the lesions there. You can see there are 2 periventricular areas. You can see there's 1 brainstem, and maybe another 1 cortical. So we have more than, or 2 or more than a topographical area. So in these cases, usually we either follow up the patient or we offer them CSF analysis. So if we offer the CSF analysis and came back positive, by 2017 criteria, we could not say that this is MS. Now there are some studies saying that we can treat RIS, but still the diagnosis is RIS. But now with the new criteria, this is MS, and then treatment can be initiated. So just to sum up, what the 2014 have highlighted is RIS is MS in specific situations. The optic nerve now is in 5th topographical area that need to count in the diagnosis for MS. Now you can use the free kappa light chain as a tool for diagnosis, and it is interchangeable with oligoclonal. The addition of the central venous sign or paramagnetic lesions is an optional tool in the diagnosis, especially in specific situation that we have talked about, those who are prone to have white matter lesions like either migraine or all the patients. And don't forget that MOG is an important also paraclinical ancillary test in pediatric patients presenting with MS syndrome. That was my last slide, and thank you very much for listening.
Please have a seat. we're gonna open the door for Q&A. But is there any question from the audience? Or we can give Dr. Tissam our prepared question from the website. Dr. Tissam, do you think using a central enzyme is going to be applicable for all hospitals, especially those using the stereotype sequence? Is it to be more applicable or to be difficult in the future?
Maybe I have highlighted that or commented on that during my speech, that probably it is useful, of course. It increases your specificity for multiple sclerosis, especially in those who have already a white matter region. It might increase your sensitivity specifically for patients with, for example, RIS. But the problem is that personally, I think it will be something it might take a few years in order to be implemented. A lot of our hospitals still don't have the 3 Tesla MRI, and it's something you need to have a trained radiologist in order to apply it, because it sometimes can be time-consuming in order to take each lesion and see if there's a central venous line. And maybe a radiologist will be the best person in order to answer this. And I think their input will be very valuable in this case.
So we need more for more trained people. We need to modern our facilities to encourage the new criteria to be applied. Thank you so much, Dr. Sam, and we can execute it to the discussion.
For the invitation.
Let us introduce our next speaker, Sami. So this is the moment to introduce Dr. Majid Abri, our next guest speaker. Dr. Majid is a consultant in neurology and neuromuscular disorders. He is an assistant professor at the College of Medicine at the Imam Faisal University, a director of medical services at King Fahd Hospital University. He did his fellowships in Toronto University of Canada. Dr. Majid, he will talk with us about an important topic about aging with multiple sclerosis. Please, Dr. Majid.
السلام عليكم. شكرا دكتور حميد وشكرا أرفع. So I'm just going to go through my voice شوية خاصة. بسم الله. Okay. So our talk today will be the aging with multiple sclerosis. So what will happen when people get older? What's the impact of aging on multiple sclerosis, and what also other comorbidity can affect people old with multiple sclerosis. So this is our objective. We'll talk about the impact of MS and aging on MS course, also impact of comorbidity, understanding of and comprehensive assessment of older age with MS, and overview of disease DMT with older aging in multiple sclerosis. So it's important for all aspects: neurologists, radiologists, nursing, allied services, and also AI, engineering, everyone. I think interested in this talk. So we'll start with the impact of MS or aging on MS. So this study in 2019 and 2022, they showed that in the state more than half of the patients they shipped to old age, more than 55. Most of them are women. So the history of MS since 1420, but the modern medicine, let's say before the 60s, then the first reported case. So most of the patients today was in late 60s, 80s, 70s, now almost about 55. So how to deal with such patients, how to see the progress, and how to see the impact on age. So what's the impact of the ecological influence on aging with MS? It's relapse will be less, fewer active lesions on MRI, but they have a worse recovery from relapses, and they have increased progressive course. And these, the influence or the impact through these mechanisms, either through something called leukocytolemia, which is a telomere, which is the key marker of giving the prognosis. If you have short telomere, it's microcellular, that you have more disability process, and if you have longer, etc. And also the productive age, and of course the comorbidity, all together can impact the MS in older age. So this is what I mentioned. So this is really something new, not new to us as neurologists. It's microcellular. So the leukocytolemia is the marker of biological age. So when it gets short, it gets more high stability, progressive disease through two mechanisms, something called inflammation and immunogenesis. Of course, in productive yield, so we have estrogen is neuroprotective for both men and women, and during the menopause, the estrogen level drop dramatically and will get more relapse or more disability and progression. So this is just a case, a lady, she's 69, diagnosed in 84 with multiple sclerosis, and after that, because of optic neuritis, after 2 years she developed occasional numbness. The last relapse was in 2006, and this is published in 2022. Then presented with 1 year of history of affecting of the right limping and right leg difficulty in climbing stairs. So they refer to a clinic for the option of DLTs. So this is well-known phenomenon called PIMS, which is progressive independent of MS. So it's part of aging. She has either musculoskeletal disorder, she has or neuropathy, polyneuropathy, or premenopause, poor mental health, or sometimes healthy aging. So what about the comorbidities in multiple sclerosis? Of course, as any disease, any comorbidity can progress or can increase the disability of any disease. And this is the common comorbidity in older age. Hypertension, dyslipidemia, and heart disease, and diabetes as well. So it's get more and more MS patients, especially it's not in MS in all neurological disorder or all. And this is study done meta-analysis for all studies for what's the comorbidity, or what's the impact of, or what's the predictor of multi-comorbidity on multiple sclerosis patients. They found older age number one, being female is number two, and of course physical disability. Efficiency, it's about 6%, so again, most common morbidity and multiple sclerosis in older ages is just getting old. Of course, the impact of comorbidity on specifically old MS patients is relapsing, many relapse the patient will get. Also the physical disability, if you get progressive in early age or late age, transition from relapsing limited to primary to secondary progressive, quality of life, of course social life, and mortality. What other common age-related comorbidity in MS? It's not the only MS, I think all healthcare. So number one is vascular, like heart rate, cardiac attack or stroke. It's increased with MS patients. We found it higher than the regular population, and also the risk is, I think, because of the risk factor in the people with the risk factor of vascular disease, it's of course increased the progression and disability, median time, especially for the disability scale. What about infection? Being older age with MS, of course, will increase the risk of infection, pneumonia or recurrent UTI. And osteoporosis, of course, this is something we missed, and the recommendation each patient with MS with older age should do DEXA scan just to diagnose osteoporosis and to treat it. So to conclude the aging, so age has a major impact on multiple sclerosis as on any other disease. Mechanisms include either reproductive or immunosenses, which is aging-related comorbidities. Also, it's common in people with MS, like infection or vascular, which cause more disability. And of course, we have to address the related comorbidity in order to it's a key factor to comprehensive MS score and treatment. How to assess older age with MS? We have good geriatric medicine in our hospital, so this is the approach for all patients, all senior, we call it senior residents or older age. So we have to address all these aspects in order to get proper approach for assessment. Of course, we have what to apply in young, which should be applied in all, but we have specific say consideration on older age, we have to be specific. And area of focus is comorbidities and polypharmacy. Polypharmacy means patient being on multiple medication. Of course, virility, which is equal to fragility, mental health, and of course, another factor sometimes for healthy aging, so could be nothing except for healthy aging. This again, this is we just mentioned. So frailty is this is taken from the Journal of UK. They give a definition. So it's an age-related syndrome, physiological decline characterized by marked vulnerability at their health outcomes. So patient unable to do some tasks like do we have signs and symptoms? So patients with virility have more falls, which is the most common neurological sign or symptoms in neurology disease in general, or the reason for admission in neurology is frequent falls in older age. Of course, immobility, delirium, incontinence. And when it comes to signs, of course, weight loss, intentional weight loss, feeling exhausted, loss of energy, and reduced walking speed. So how to be? You have to be proactive. You have to assess all these through dietitian, make a dietitian, weight to look for reason of weight loss, muscle strength, do resistant exercise, and others. This is the cycle of virility when the weight gets lost. What will impact on the strength and walking speed and activity. So it's a vicious cycle. That's why we have to understand or to have insight about virility before jumping to the progression of MS per se. Of course, mental health, not only for all, for young, and after COVID in the States, the mental health diseases increased by 65% according to the WHO. So this is just to prove that mental health is important and gets worse with aging. And of course, we have to focus on specific diseases like depression, anxiety, dementia, sometimes mixed up with MS progression, whereas the diagnosis is dementia, and of course, mental health recurrence. Of course, socialization or loneliness can affect the MS, old age of MS, or just aging, old age in general. So addressing this issue again it might impact on good prognosis for patients with MS. And this is how to approach or how to address this ability by, of course, being active, getting enough sleep. It's not for us, it's for us actually, except for drinking. So what is the biological and chronological age? So biological is how your body show. Chronological is what you actually. So when they said it means it's a biological. So some of the people, the chronological age is 60, which is the active, but the biological is 40 or 30. Depends, of course, on physical activity, stay good mental health, and stay away from stresses, and etc. So in summary, course assessment should be focused in multi-area, addressing the polypharmacy, addressing the impact of healthy aging, and of course it's not about biological age, it's about, not about the chronological age, it's about biological age. Last topic we're going to discuss is just overview of DMT's therapies in an older patient. When to start, when to stop, what's the evidence behind these. We don't have much data on discontinuation except for one. I'm going to show this. So this is the meta-analysis showing that among almost 67% preventing disability progression could be explained by age. And model predict effect on DMT's disability progression after age of 53. Meaning that, which is the question now, shall we discontinue the DMTs after 50 years? Or 40 years of 40 is not the age, the 40 years, or after age of 53? And the answer is, so this is the answer. As are the DMTs safe in an older patient? It's kind of a tricky question, but there's some data show that these cell therapies, especially for using for more than 40 years, can increase the risk of malignancies, but we need more data to support this or to predict. So this is the only study, the only randomized non-inferiority study of DMT discontinuation. So they include age MS patients above 55, DMT treatment minimum 5 years and maintain on recent at least for 2 years, and they conclude with no new lesion in the previous 3 years. So they conclude, of course, this is the first randomized DMT discontinuation. Although there is stopping DMT, it was not inferior to not stopping, but the relapse rate were low in both groups, except for one patient who got a relapse, who stopped DMT then got relapse. And so there is no difference in rate of disability progression over short period of time. So again, now we need more supportive data to conclude that, or to easily, or to assist with the patient answer, yes, we can start or we can discontinue the medication. And this is just the bridging treatment, when to stop, when to start for in older age, if he starts on a certain rule like anti-CD20 or S1P. What about polypharmacy in multiple sclerosis? Also, this has been looked. Almost 10 to 20% at the age of 40 to 65, they are on polypharmacy, and it increased to up to 35 above 65 age. So, what to do? Stop medication. So, of course, we should treat the patient individually, consider comorbidity as a risk factor, and de-escalate, again, it's debatable, give lower drug risk or class, lower risk class medication. Again, this is debatable. Stopping the treatment, we have only one randomized study which is support, but we need more study, I think, in the future. So this I conclude. Thank you.
Many thanks for this speaking with Dr. Majid Al-Abdali to take the time and sharing his knowledge with us. Dr. Majid, would you mind to allow us to open the Q&A session? If there is any question from the audience about aging with multiple sclerosis. So, in this case, Dr. Majid, we received a question from the live stream. They asked about what do you think regarding, let's say, 50 years old male who slowly progresses his progressive less cost. Would you start him on ocrelizumab?
So, for now, yes, because we don't have evidence to start or to not start. The only study done for relapse inability or for patients who don't have new lesion for the past 3 years. So, going back to the evidence, yes, we should start the patient at any age, older or younger, according to the evidence we have. But I think the game will be changing over the years because since this study become positive, I think more studies will come to see if we can stop it or not. But for now, we should stick to the evidence to start to treat any patient who fit the criteria, either from relapses or from primary or secondary progression.
Thank you so much, Dr. Mark, for your informative lecture. Let's pass to the next lecture using the artificial intelligence in multiple sclerosis field. It's an attractive topic, and our next guest speaker will tell us more about this topic. Please welcome Dr. Mustafa Yaldish. He's an assistant professor of computer engineering at Faisal University. He had a PhD in computer science from Australia. He is one of NVIDIA ambassadors. Dr. Mustafa, floor is yours if you are ready.
Assalamu alaikum everybody. Peace and blessings of Allah Azza wa Jalla be upon you. And I would like to introduce myself. My name is Dr. Mustafa, and thanks for the introduction. And I work at the Imam Abdul Hassan University here in Dammam. I work at the College of Computer Science and Information Technology. And the intention of this topic is to bridge the gap between artificial intelligence, which is my area, and of course, neurology, especially in general, and of course, the pioneers in MS. So obviously with this talk, inshallah, I hope that I'll be able to answer a few questions or maybe a few thoughts that you might have, especially if you're new to the area. So again, helping consultants and pioneers, especially that deal with MS, is one of my major objectives, and inshallah, with today's talk, I'll be able to bridge the gap, inshallah. So yes, I work at the College of Computer Science and Information Technology from the Department of Computer Engineering. I also am the certified ambassador of NVIDIA. NVIDIA, of course, is the company that actually empowers AI technologies worldwide, and I have the authority by the company to basically provide professional training. Should you wish to hop on the AI journey, it's my job to provide you with the required training. And of course, I'm always here to help. Especially those in need, especially if you come to the medical community. So this is just a proof of my certification from NVIDIA, and it was inshallah, if you have within the private time, I'll explain how this actually relates to the medical field, because it's quite interesting. Speaking of again with MS and also in medical science, and also with healthcare, it's also a passion that I actually have, and I love to always learn about what are the current challenges, especially in neurology and of course in the MS domain. And I got a few training opportunities with MIT recently, and of course Udacity, to understand the actual requirements and the challenges that you might actually face. And these are some of the certifications that I got. So I'll skip those for now. So like I said, with NVIDIA, we basically provide the opportunity to universities especially, and of course, institutions, public and private, to be able to train them, and of course, empower them with the latest technologies, and of course, with the latest training opportunities, inshallah. So again, feel free to talk with me, inshallah, after during the exhibition. I do have a booth that we represent one of the major milestones that we achieved. And inshallah, I release, of course, to multiple sclerosis, identification, and lesion segmentation. And I'll talk about this topic at the end of my talk. So the training actually extends worldwide. In Saudi, we are very limited. So the number of certified instructors are very limited. And alhamdulillah, I have the opportunity to represent the company here locally and of course exclusively, especially with Imam Abdul Hassan Faisal University. So the agenda is always challenging within 40 minutes or so to deliver a talk that is pretty much comprehensive, especially when we have a mix-up audience. Because my background is basically in AI, so the point is, how can I bridge the gap? How can I basically explain the topic? So I'm assuming, I just want to really know, how many of you actually have some idea of what AI is, to some extent? I just want to see hands. At least something basic. Okay, what about ChatGPT, for example, in these websites? Do you use them a lot? Okay, that's a good sign. Okay, let's continue. So for those who don't really know what AI is and how does it fit the model, like how does it relate to MS? Oh boy, it really has a big role, especially in changing how things are actually done, especially with the accomplishments that are being published nowadays. So I'll give you a brief introduction about what AI is basically, and by the end of the talk you will at least understand the basics, of course not all the technical jargon. And again, one of the challenges that I discovered is that, of course, as a medical expert, you might actually see situations, like especially with case studies, with like the different patient situations, that not every case can be actually due to MS. It could be something else. The patient can be diagnosed with another neurological disease, for example. So AI can aid medical experts in actually identifying these situations. So again, I'll briefly cover a few situations. And of course, one of the challenges, and of course, in AI, how AI can be actually utilized, and all the challenges in general that can be presented. So these are the main topics that inshallah I'll try to cover within 40 minutes or so for this. And of course, the key findings from the publications. This is the most important part, and the time will prevent me to cover every single detail, but we can actually meet inshallah during the exhibition, and we can talk further about the most recent accomplishments or innovations that you can actually benefit in your own career. So this is basically the agenda. I'll just begin right away. And of course, I'm more than happy to answer questions. Alhamdulillah, I have some extensive experience, and I would love to learn from you as pioneers, especially if you come from the medical field. So, what is AI in general? So, I'm assuming, again, like I said, maybe not everybody knows what artificial intelligence, or like in Arabic, the kind of science is. So, again, what is AI and what is basically intelligence? Of course, if you come from a medical background, you would define the term intelligence, of course, like from how a human being actually perceives it, or how it can actually academically be defined. So, does it relate to AI? Of course. It forms the foundations of the field. So, again, what is AI? It's basically, you can think of it as a sort of a simulation, muhaka, simulation of the human brain, especially one of the actually subcategories of AI, sub-disciplines of AI, which is called deep learning, which I'll briefly talk about. This is the field that actually shines now. It's one of the reasons why ChatGPT and these large language models and these new generative AI tools are everywhere. You always hear of new innovations and new technologies like everywhere. If I ask you this question, generally speaking, before the ChatGPT boom, what do you think AI would be basically? If I said if it's a simulation of the human brain, okay, of course, the human brain is pretty complex, as you know. How can we actually simulate all the functions that a human brain can actually perform is almost next to impossible nowadays. But if you want to try to think of the crossing between either thinking or, let's say, acting, either humanly or rationally, which one of these can define the basic terms of AI, only the basic principle? Which one do you think? Think about it.
Thinking rationally.
Thinking rationally, possibly, yes. Are there any other answers? Okay, so for the sake of time, I'll just show you. Maybe you got the answer right or wrong, we'll see. It's basically acting rationally. It's not just thinking. One might argue, would say maybe now, because after you use these tools like ChatGPT, again, the innovation or the invention of, let's say, large language models is actually redefining what AI can actually do these days. Because again, you can come up with innovative solutions that can come closer to what a human being can actually do, but still with a lot of limitations. So. Again, one might argue, but again, you can also go back to the literature and understand why. Okay. So, let's continue. obviously, the definition of intelligence, of course, encompasses how AI actually can be built. So basically, one of the examples is the ability to learn and adapt. So when I say learn and adapt, you can think of actual software tools, like programs that we write, that can learn by themselves without us interfering by any way. And this is how now AI is basically seen these days. So this is one of the examples that we see. So forms of AI, of course, we said ChatGPT. That's one of the websites or tools that we use. There are also obviously so many examples of where AI is actually found these days. One would be, of course, a term which is called Internet of Things, or IoT, where you can basically control your own house using AI these days. And of course, you have gameplay. Traditionally, of course, you can find smart, so-called smart characters in the game, and then you can actually compete against them. That's another form of AI. Of course, you have face recognition. When you have a so-called smartphone, when the phone actually realizes that it's you and then unlocks the phone, that's another form. And you have speech and language. Of course, you can think of two areas where if you have a program where it can actually understand what you're saying, even like in Saudi, you have different dialects, lahjat, So this is also a challenge. Can AI understand? Now we can. Before, like a few years ago, it was really, really challenging. And of course, with the pandemic, a lot of things happened. Imagine even with MS, with the MS diagnosis and also identifying the types of MS is now easier because of the pandemic, because of the need for the use of AI to solve this, to actually aid physicians in what they do. And of course, smart solutions like drones, for example. You can just basically deploy an AI program and then make the drone actually act in a so-called smart way. So how far has it gone? It's basically changing every single day. Every single day, we would hear that a lot of innovations, especially in the medical field, for people like us, we actually go tired, that we get so exhausted by actually discovering so many innovations in healthcare, especially in MS, in identifying multiple sclerosis alone. That's a big topic by itself. But there are just in an abstract fashion two distinctions. There is the weak AI and there is the strong AI. Weak AI is basically a small program or task or agent that you design that can accomplish that task, and that's it. So that's the basic definition of a weak AI. And that's it. Of course, if I ask you for examples, you can actually think of the simplest applications that nowadays that are used. Strong AI, you can think of maybe ChatGPT as one of them. Another application would be something that it can rely on helping you diagnose a patient that can actually aid you if this patient has MS or not, for example. It is now possible, and that can be categorized as a strong AI solution. So the few misconceptions. I want to ask here the audience, is anybody here a radiologist? Anybody who comes from a radiology background, especially? Neurology? Pretty sure a lot. Okay. The reason why radiology is the first thing that I would mention, because it's the easiest area that can be actually, I'm sorry to say this, can be replaced, again, we can argue about that, by AI. Because basically, will it replace all jobs? Obviously not, you don't have to worry about that. But in the medical area, there's a lot of debate now. There are many also authors, good authors, who are actually talking about this topic, because again, it depends on where you live on the world, what are the policies, what are the implications of using AI, what are the ethical standards or issues that you might actually face. So rest assured, there are no jobs that are going to be diminished, but after a few years, things might actually change. So remember this talk, remember like in a few years' time, things are actually going to change. So just for the sake of time, I'll skip. Of course, can solve any problem. Now with the use of websites like ChatGPT, of course you have now a better chance of understanding what AI can do. But of course, you have to understand that also there are many specialized tools that can actually be really interesting to know that if it's safe to use in an environment, especially in the medical field. So it's a tricky sort of situation. There are three main distinctions in AI, just to give you sort of a clearer picture. So AI, or artificial intelligence, is the big bubble. And we also have machine learning, وتعلم الآلة in Arabic, which is a subfield of AI. And of course, the most important domain in healthcare, medicine, is now deep learning. So that's the third subcategory. There are others, like generative AI is actually part of deep learning, and I'll get to that briefly. So AI, like I said, is the main area that is moving away from the area of computer science, just to explain this. But so machine learning, وتعلم الآلة, is basically focused on data. If you have good data, like for example, patient records, for example, you can actually use those and design a software system that can actually predict and tell you and can give you an indication if the patient actually has MS or not based on the patient history. It is possible, but it's very limited. So again, this is the general picture. What about deep learning? What made it so special? You remember one of the slides that I said AI is a simulation of the human brain? What if I told you that it is now possible to kind of simulate the actual actions in the human brain using, of course, neurons and interneuron communication? And of course, this is where deep learning comes into play, where we simulate the behavior of the human brain using something that we call the artificial neural network. Okay? So it's based on that, and it's because of this field that AI is so famous now. So remember what I said, generative AI? So generative AI, or in Arabic, الدولي, is what we're seeing nowadays, and what is actually making a lot of hackathons and a lot of opportunities, a lot of especially experts in the medical field, actually join the club, if you may well, and conduct their own experiments and use AI technologies with ease. Honestly, you don't really need experts now. Why? Because it's very easy for anybody to learn, because the information is out there, the examples are out there. So it's just a matter of knowing what you're doing, and that's it. You're basically empowered now. So that's, again, the generative AI, of course, a lot of it's the future. In all honesty, it's actually the future, especially in medicine. And there's another technology that is also important in healthcare, and that is called, what's the thing that can come into mind when you see this picture? It's two phrases, two words. It's a technology that not a lot of people know about, but it's really important, and some medical institutions are actually employing this key technology. What do you think it is? It's called digital twins. Have you heard about it? Digital twins. Muhaka. Imagine yourself conducting an actual surgery, but of course virtually. So imagine the implications, imagine the benefits of this. So it's there, and of course it's not the topic for today, but again, if you'd like to know about it, we can talk after the session. So why, of course, AI now? Why the boom? Why is it so important? And of course, two factors that made it possible. If you come from a medical background, you know that many medical hospitals that actually host a lot of data. So data is now more valuable than gold, in all honesty. So with data, and of course with big data, which is of course another term of saying that data is available in so much bigger quantities. So the challenging is how can you actually make sense of the data? The second part, and that is utilizing special hardware, special equipment. And if you visit us in the booth, I'll show you one example of one device that actually enables. If you visit the booth, you'll see this device on the left, which I have on the computer, and that is called a GPU, a graphics processing unit. It's the device that is responsible for drawing everything on screen that you see right now. We use it as a means of performing fast computations. Like for example, I will send it a list of MRI scans, for example, onto the GPU, and then it will actually train an AI application, and then I will test it out and see, and ask this application, does this patient is diagnosed with MS? What type of MS, for example, that you as a software tool can tell me about? And it's through these devices that AI is now basically enabled for. So with medical AI, and of course with multiple sclerosis especially, it's now more important than ever before that we have to hop on this train, so-called train, basically, because again, with technologies, a lot of things are actually happening, especially, like, for example, what interests me is what Dr. Tissam mentioned, that is again, like the criteria that you basically follow that can define the stages where if this patient actually is supposed to be diagnosed with MS or not, and what are the implications, what are the basically chances. This can be automated. This process can actually be integrated into a bigger solution where AI can actually solve, either partially or in full. But again, this is a general challenge, and it's up to you to think of whether a subset of this strategy can be implemented or not using artificial intelligence. So it basically allows you as medical experts to come up with various or innovative solutions that were otherwise really challenging. So of course, the interesting thing to think about Dr. Ibtisam's talk, and that is, if an institution has the proper equipment, like for example, new advances in MRI machines, for example. What if an institution doesn't have? Is there a way to overcome this issue? The answer, as far as we understand, is yes. There are shortcuts, for example, depending on what sort of hardware limitations that you have as a medical institution. You still have a chance in actually utilizing AI and for example, to identify if a lesion, for example, in the brain that actually exists, is an indicator, a clear indicator if a patient actually is suffering from MS, and of course to what type, like which classification can be assigned to the patient. And of course, with medical imaging, it's really vital, really important for an institution, for anybody who wants to do AI research, is that you have to have or obtain reliable data, especially with images, like with MRIs, CTs, X-rays, and so forth. The type of data and the quality of the data actually depicts or determines whether you can actually move forward and conduct any AI experiments or integrate AI into your institution. And yeah, so again, AI and big data, you'll see these terms interchangeably nowadays. Okay. So of course, with large data, of course, comes a lot of opportunities and a lot of challenges. And of course, the big question is, how can you actually manage the data, especially if it's big? Of course, you have to have specialized environments to do so. The thing that I want to point out is, now it's easier than ever before for any medical physician to basically join the AI club and basically utilize open source technology. What I mean by open source is that there are available tools and collaborations, by the way, from also medical experts from many domains, and to, for example, utilize something called MONAI. This MONAI is basically a project that is open source, freely available, anybody can use, and in the booth we actually have an example of using MONAI, and actually identifying MS cases, and of course distinguishing cases if they're MS or not. And of course you can perform anomaly detection, understand if there is any case that is other than MS, it is also possible. And MONAI is one of the famous known platforms, and I can of course give you more information on how to actually start using this solution in your own institution or in your own research. Of course, with classification, as you are aware, with MS there are different types of subgroups. So can AI actually facilitate this process? The answer is yes. There's a lot of research in this area. And of course, the challenging bit is to depend, you as a physician, as an expert, can you depend on the results that are provided by the AI agent or AI tool? This is the most important factor. And of course, you can detect, again, like for example, with MRI, it's complex, because with MRI, of course the data is in 3D, it takes a neurologist a considerable amount of time to basically analyze each slice in the MRI. But with the right tools, it can be done in a fraction of the time that for example, a radiologist might actually take. And of course, the early detection phase, which is really important, is again, this is really gold. It's really important to, let's say, tell the patient that the patient is more likely to actually have MS in the future, like for example, in 5-10 years, based on certain symptoms that are otherwise not directly indicated. And it's not just in MS, I'm talking in general. There are many other domains that we've seen this situation actually happen. And of course, it's nice to always tell the patient that you have to take all the precautions, as Dr. Majid also mentioned. Again, it's nice to always keep the patient aware that their health is really important. And of course, you can also provide them with the necessary guidance, especially if they know everything ahead of time. And of course, with AI, it is really possible. You can be empowered. And yeah, and with natural language understanding, it's important to bridge the gap between you as a physician and of course with your patient when you have no gaps between you and the software system that you use. And of course now it's becoming better and better nowadays, especially with generative AI. Speaking of generative AI, you can imagine the situation where you sit down with the patient and then let's say the AI actually hears the conversation and then out of the sudden, you see the software system spit out a reliable report or medical report from each session. And this is one of the applications that AI can actually perform for you. And of course, analyzing these reports. So AI for medicine or healthcare is important. This is the future. And again, with healthcare, you will see a lot of crossing between the areas. And I'll try to go a little bit fast, just to save time. As physicians, I'm pretty sure you know exactly what I mean here by showing this slide. What's the term that comes into mind? I'm seeing a lot of smiles, which is nice. What do you think? What's the term that comes into mind when you think of this? Sorry?
Burnout.
Yeah, physician burnout or burnout. And of course, how about coming up with or utilizing tools and technologies that can make your life easier? And this is our dream, inshallah, by the will of God. We will hope that we reach to that stage and we're again, by the wonderful job and work that the MS specialists and of course consultants and other medical pioneers are doing, it's nice to always give them a helping hand and of course excel together. So this is what we always thrive to achieve, inshallah. So yeah, it's basically what this is important. So in general, again, I don't have the time to basically explain this. This is a sort of a general picture of what actually happens. When you obtain the data, we actually go through the process of designing or developing a so-called model. Maybe sometimes you can hear about namudaj or AI model. It's this common term that we always use. So the application or the solution that we have is actually called a model. And how does it happen? It basically, with the reliance and the availability of data, you basically either use a model that is pre-trained, which is the fastest way in AI, where you take the work of others and then enhance it, or you start from scratch, you only use your data and then build the model from scratch. And this is sort of tedious and takes a long term, and you may either succeed or fail. It depends on your luck. And of course, I want to highlight something, and this is important especially when you think about collaborations between institutions. There's something called also federated learning. Or, again, when you have the ability to actually share your work with other institutions, privately and of course secretly with trust. And of course, this is also possible through the sort of life cycle of the workflow that we basically rely on. And of course, when you have a model that is ready after testing and then you validate, you make sure everything is okay, you deploy. And then with this term, it refers to actually giving the solution to the user, like to the customer, to for example, to your patients. If you want to assist your patients if they're at home, and then you give them a sort of a tool or an application that they can use on a smartphone or as a website. And this is the term deployment. And yeah, again, I won't go through the other terms. This is another way of saying machine learning operations, and that is a general cycle of developing these solutions. Okay. So it's really hard, in all honesty. Like especially when I learned about artificial intelligence, and again, I had to give credit to my wife, Dr. Zaki Yasawi, for actually giving me the inspiration. She's a neurology consultant that actually, through her advice, I love the idea of learning more about neurology, especially combating MS. This is my #1 dream, basically providing solutions and aiding her research and other colleagues to empower them with AI, and this is my #1 dream. So it's really hard, honestly, to basically develop these solutions and from scratch or rely on existing solutions. So the thing is, the final thing that I want to point out is that there is a lot of work done in the field. So that, like for example, is there any simple solution in AI that can basically classify the types of MS through different means? There are a lot of papers. For example, this paper about the rising standards of principal cancer research. Again, it doesn't relate to MS in general, but it's a nice read that we always recommend, and it's also provided by NVIDIA as a good reference. Inshallah, we'll provide all the links, inshallah, through after the session. We'll coordinate with Arfa, and thanks to Arfa for the invite. Another thing that's also a challenge, if you find a nice idea, how can you get a copy of it? If the source code is not available online, that's obviously a big challenge. So if you can't reproduce the concepts, it's always challenging, especially if you don't have the means to actually start working on so it's a simple idea. And of course, integration. That's also one of the challenges. If you have a good concept, let's say if it's done through a research that took 1 year or 2, how can you actually use it in the workplace? Can you rely on it in a clinical setting? It's not easy. And of course, if you heard about the FDA process of approving, like in the States, where you have a so-called medical device, an AI solution can be a sort of medical device. It can take 1 year or 2 just for them to say either yes or no. And so that they can give you a green light if your solution is safe, it ticks all the boxes, and then you can actually use it in your own institution. Depending on country or region, this process may actually vary. And of course, the number one issue that I face basically in the research is obtaining a lot of data. So luckily, alhamdulillah, we have a good institution, and we had an opportunity to collect a good number of samples of patient records, especially those with MS and without MS, just to also verify our work. So this is also really challenging. So AI with multiple sclerosis in particular, this is a nice read that I really highly recommend that anybody can read about the relationship of, let's say, AI and how can it be implemented in a more effective medium. Inshallah, we'll provide you the links later somehow. This is sort of an almost recent publication, which is a 2023 publication, and there's another one. And I guess I'll end it here. There are a number of good publications because of time constraints. I'll leave it at that. I'm more than happy to provide you with answers, inshallah, during the question and answer time. But a shortcut to start working with these available tools is something we call the Monai Zoo. And that is to download the existing models that others have developed and then integrate these models into your own, let's say, workplace or computer, if you may will, and then start testing. So anybody can basically start learning using AI with ease. So it's not like before. Anybody with no background can basically start learning. And thank you all. Hopefully, inshallah, I'll finish in 40 minutes or so. But I hope, inshallah, I inspired you. Hopefully, I give you a little bit of like a good idea about what AI is. And if you have an interest, especially with relationship with AI and MS, I'm more than happy to provide you any answers if you like. And thank you. Jazakumullah khair.
Thank you so much. Thank you so much, Dr. Mustafa, for your informative lecture and to illustrate the big theme of AI, using AI in the medical aspect, especially in the multiple sclerosis. We're going to open the Q&A session. Is there any question from the audience about using AI with the neurology field or the MS field? Yes. Just a quick question, if you may, about Monai itself. So if like a normal person downloads Monai and wanted to integrate it or try it out, is it easy to, for example, upload images that we have, or how do we integrate our skills into Monai? That's my question.
It's actually a common question, a very good question, because again, everything really depends on the data. So if you actually have a good sample, and that's the tricky part about AI, the more the better. If you have a good so-called data set, for example, and then you still have to do something that we call exploratory data analysis, which means you have to investigate and tell yourself if the data is reliable or not. Because if, like for example, you can spend a lot of time gathering hundreds of records, of patient records. Let's say MRIs, for example. You want to develop a solution, or just use something that is readily made, developed by others, that is, say, published, that actually can help you in identifying the lesions in an MRI, for example. The issue is if you want to, let's say, train something similar okay, with the data from scratch, and then your data is unbalanced, but you don't have a good ratio between, like, let's say, patients with no cases or patients with cases. Because with the development process, you have to split the data into, like, for example, a training set, and then an optional validation set, and the third important thing that is testing. What we did with our project at the Imam Al University, we obtained data that was available with ease. Like, there are certain websites and services that anybody can actually see and use. They can download the data, no problem. And it basically encompasses a lot of cases, not just MS, other cases as well. So the challenging bit is, can we rely on the data? Are they actually existing MS cases from before? And it's not just that. The quality of the MRIs, are they good or not? Then that's okay. Let's say assume that everything is fine. Can we obtain new data? And this is the golden thing. So if you have an opportunity, you want to test something with value, use data that the model hasn't seen before. Because you don't want to go through a process that is called, let's say, overfitting. You don't want to develop the perfect solution, but then in reality, when you deploy it or give it to someone else, like your institution, it fails miserably. Why? Because it didn't train well. Because it trained perfectly on certain data, but then in reality, it fails miserably in one or two tests because it hasn't seen this case before, it hasn't been trained on it, you know what I mean? So data is important, just to sum it up. Data is important, and of course the variety, and of course the sources of the data can be, of course, a question. I'm not going to be talking about ethics, because again, it depends on how you take the data, and if you have the rights to actually publish the data. So this is another topic, but inshallah maybe in the future we can talk about it.
Thank you so much. Yeah, Dr. Mustafa, let's make the question more simple. Do you believe in the accuracy of AI to interpret or treating all types of MRI for all MS spectrums or diseases? As we heard from Dr. Tissam, there is a new topographic areas like in optic nerve. It is included in the new criteria. Do you believe the accuracy that will be higher with different types of MS, or there's some restrictions?
I love this question. The reason why, because I'm actually having almost daily arguments with my wife about whether AI can automate these processes. Like, again, I also had an interesting chat with Dr. Ahmed about this before the talk. And just imagine, can the criteria be rewritten again and again because of AI? It is possible. I don't want to promise anything. I can't speak on behalf of somebody else who's doing good work in this area. But it is possible that even the textbooks can be rewritten because generative AI alone, the customer ability. Because again, you're talking about established criteria that, again, this is the work of physicians around the world, that they were trying, because with MS, it's always challenging. You can't just rely on like MRIs alone, though it is possible to reach to a certain conclusion with good levels of accuracy. Like, for example, the accuracies of these models can be misleading. For example, like with the work that we have, we reached a fairly good 96% accuracy. But if you ask me, it's not enough. Because sometimes models, like we see this a lot with AI applications, people brag about publishing accuracy levels that are convincing, and then you will say, contact the authors and obtain permissions to use their models in your own setting. But it's tricky because, again, when you test it out using certain data that, for example, it hasn't seen before, it might fail. Or it can reach to a certain conclusion that is not desirable. Like, for example, if a patient does not really have MS, where I've seen, for example, situations where patients actually appear to be MS, but their actual diagnosis is not MS. It's basically migraines, like long-term migraines. It happened, and I've seen these situations before. So imagine where the model or the solution that you use can actually be good at one stage, but it might fail or might not be integrated well, or you're basically misused, or it's not suitable for the setting.
Yeah, thank you. I found Dr. Ahmed. Do you have any question for Dr. Yusuf, or we can pass to our next session? Okay, so dear audience, we have heard a lot about using stem cell in therapy, many medical aspects, but not in our routine MS practice therapy. However, in this reason, we would like to welcome our next guest speaker, speaker from our capital city, Riyadh, Dr. Ahmed Abu Laban, to tell us about using stem cell in this field. Dr. Ahmed is an assistant professor and professor of neurology in King Saud bin Abdul Aziz University of Health Science. He's a director of neurology residency program, training program. He did his multiple fellowships in neuroimmunology, in multiple sclerosis, and clinical neurophysiology from Yale University, United States of America. Please, Dr. Ahmed, the floor is yours.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Wassalamu ala Rasulillah. Thank you, ARPA, for the organization of this really wonderful meeting. I would like to start by saying really nothing compete with AI. You know, if you talk, I want to even just discard my presentation and spend the whole time speaking about AI. So I want to answer the questions you answered. And I'm a physician, and I said yes, AI can be accurate, but it depends we're talking about the appropriate setting. So still we did not reach the appropriate setting. The appropriate setting was trained with huge, pure clinical data, with the right, really challenging clinical questions. Definitely, it will grow. I mean, with regard to the change of criteria, if you think about the criteria, how do we look into the criteria? Why the criteria change in the first place? The criteria change because the 2017 criteria doesn't solve some of the clinical challenges that we deal with. So with the new data, now they did this revision. And I can tell you right now, there are still with the new criteria, there are challenges, and there are cases that I will call them MS as an expert. As I know, I've seen many patients like this. So the criteria should evolve. The criteria will evolve over time. And remember, mark my word, the criteria of multiple sclerosis will change. Even in 2024, it will change. We are dealing with a syndrome. So the multiple sclerosis is really a diverse and heterogeneous disease. So if you really understand the MS from the deep inside, it's actually a constellations of many syndromes or many phenotypes that they behave differently and with different outcomes. That's why it's so complex and dealing with the sophisticated part of our body, and it's really complex. So I think definitely the criteria will change, and AI and clinical expertise will work together. And we just always, I like to say, it's not the question is, will AI replace physician? It's not like that. Physician who use AI will replace physician who don't use it. So this is reality. So I will speak about the stem cell transplantation in patients with MS. It's really an interesting concept in some patients. In the old days, it started to grow very rapidly, but then something happened and it's like it slowed a little bit. And do you know why? What's the reason for that? The presence of highly effective therapy, and now it's really a big competition now by simple medications that really can have the same effect as the stem cell transplantation without going into all the risks that can happen. So I will review basically. I promise you, I will not take long time, so I'll be very quick and efficient. So what is multiple sclerosis? I'd like to speak a little bit about the disease. It's an autoimmune disease that affects the central nervous system, so the brain and the spinal cord. So we have autoreactive lymphocyte, crazy lymphocyte that attack the central nervous system and cause the demyelination. So if you look here, the disease process started a long time ago, even before the first clinical attack. If you have a portable mouse, because this one, the laser point doesn't work on the screen. If you have it, it will be nice. If you look here into the first clinical attack, even when the first time you see MS patients, the first clinical attack we know that this started a long time ago. We cannot catch the patients at the beginning. Why? Because the locations, depend on where is the lesion. So, now with patients with time, they can either have just one attack or they can evolve into another attacks. And if you look into with time patients, they can develop inflammations, and they can have they can go into the phase which is we call the neurodegeneration. Why it's important to understand this graph is because in every MS presentation, early treatment is very crucial to stop the inflammation and stop the disease progression. There is a window. If you lose this window, then you really cannot do much for the patients, at least for the current evidence. So the earlier you work, you introduce and you treat MS patients, always the better outcome you will have. And one of the reasons that the lesion can happen anywhere, and if you look into sometimes the brain, is very huge, and can have 1 or 2 lesions without causing symptoms. So the lesions will not reach the clinical threshold. Okay? Compare this to the spinal cord. Spinal cord is very tight. If there's any inflammation there, it causes a lot of symptoms. It comes to the surface very quickly. So the location really dictates how the patient will present. And if you read all the pathophysiology paper in MS, it's really, you think it's crazy, but I really can summarize them in one line. We have autoreactive lymphocyte, crazy, which penetrate the blood-brain barrier and cause the inflammation. Now, these autoreactive lymphocytes, just in simple terms, lose the balance between Tregs and T effector cells. So the cells that drive inflammation and the cells that protect against the inflammations. And everyone is really excited about the story of EBV. EBV now, EBV increased the risk of MS by 32 folds. That's really a huge increased risk. By the way, in the 60s and the 50s, everyone was smoking. No one was aware that smoking is #1 cause of cancer. Now, if you ask anyone from the street, he will tell you right away. Smoking increased lung cancer by 30-fold. EBV increased the risk of MS by 32 folds. It's equivalent to smoking and lung cancer. But here is the 1 million question. How? So everyone is really trying to understand what is the pathophysiology. And now, in MS, we have the neurodegeneration where you have multiple mechanisms. So MS is, I like to call it, it's 2 phases, or 2 sides of MS. We have an inflammation, we have the neurodegeneration. We understand the inflammations very well, but we don't understand the neurodegeneration because it's very complex. We do very poorly in basic science. We don't understand what's the exact mechanism. We don't know. We cannot pinpoint exactly in which point of time patients can develop neurodegeneration. So it's really challenging. So if you think about it this way, so it's what you have. This is oversimplifications of what's happening. So you have inflammations and you have neurodegenerations, and there are variations. And if you look in early on, you can treat with inflammations. With neurodegenerations, still there are 2 aspects of neurodegenerations. You have first how to treat the neurodegenerations. This is one aspect, and the second aspect, how can you regenerate lost neurons, remyelinations. Still, if we compare the level of achievement between treating inflammations, it's here compared to nothing in neurodegeneration and remyelination. So a lot of work can help. Genetics plays a role, and we can but it's not only enough. So it's not bad genes, by the way. It's bad interaction between the environment and the genetics. What are the limitations of the current DMTs? There are many limitations. Patients will go into long-term immunosuppression. So what if we can just treat the patient with one shot, transplantations, and then that's it? Will be a lifelong effect. We have autologous and allogeneic. Autologous, you mean you take the patient's own stem cells and you give it back to them. And stem cell is like just doing in like computer terms, just rebooting the immune system. So you take the stem cell, you ablate, you take all the immune cells, and then you give the patient's own stem cells. And it's and it goes through a process. I'll go with each one in very simple terms. So first, you give the patients GCSF, which is colony-stimulating factors. This will allow for this hematopoietic stem cell to mobilize from the bone marrow and from the periphery to be. Then you do apheresis. So you take them out, okay? And then you give the patient chemotherapy without radiation. And then the patients will be, you resume back A and D, you resume back the patient's own stem cells, and the patients will last in the aplastic phase. They will stay 10 to 20 days until engraftments. Engraftments until you have the immune system reboot back again. So this is again. So you first give the patient the GCSF, growth colony-stimulating factors, and then you isolate the patient's own stem cells, and at the same time you give them intense chemotherapy. So you wipe the immune system. This stage is really very critical, where patients will be immunocompromised and liable, and this is the period where the patients have risk of even mortality. And then you reinfuse the immune cells again back to the patients, and then you see the effect and you monitor the patients. Now, the immune, this is considered immune reconstitution therapy. So it's, we have a medication now that can simulate this. So it's really competitive nowadays. When we talk about the outcome that we want to look, we want to reach something called NIDA, which is no evidence of disease activity, and you want lifelong remissions. The problem with MS is it's really a chronic disease. So if you treat the patient to something, the patient is disease-free for 1 or 2 years, still you cannot tell. So you need really long time to prove that you did something, and that's really one of the challenges in treating MS patients. I discussed the differences between the old platform therapy, where you give the patients chronic immunosuppression, where in a transplant you give just one shot. So there are the earlier studies, you know, the animal models. EAE, the autoimmune encephalitis, it's the model. It's not really the perfect one, but it's the best one to simulate MS. It shows very significant result. When we do also the stem cell transplantation, there is two main types: myeloablative and non-myeloablative. What do you think the difference is between them?
Using chemotherapy, one is with ablative and other method is the non-myeloablative.
So the myeloablative, you mean it's you really give the patients, you wipe out the immune system completely, and I think it's more effective. And now some studies started to show comparable efficacy but better safety, because you don't really deplete the immune system. However, the one we do in our center is really myeloablative, because we think it's really, if you're gonna go this road, I mean, you should really overkill the immune system to make sure that you don't have any chance for disease recurrence. Some centers, even with the stem cell transplantation, patients can have recurrence of disease activity. Patients will pass into an aplastic phase, and then they have recovery of cell counts, and then they have engraftments. Engraftment is slowly growth of the patient's immune system. Do you expect to see graft versus host disease?
It's the same patient.
So yeah, so it's the same patient's cells, so it's there is no chance, but they can have engraftment syndrome, and could be early or late. You want to see something called progression-free relapses and progression-free of disease activity. I will show you the result from the systematic review on graphs. Let's just go to the graph. You have to also manage the patients during the toxic phase when they have really. So we're talking about serious complications. We're not like in disease-defined treatment. You have to have justification to use it. Patients should have at least really highly aggressive or at least fairly highly effective therapy. We're talking about mortality here, so it's a no joke. Internationally, the percentage is ranging between 1% to 3%. Most of the new centers are like around 1%. In our center, we're lucky. We have very advanced care. We have 0.5% mortality and morbidity. And even this number is for all transplant, not for MS. For MS patients, since we are very selective, we don't have any mortality because we are really very selective. We select good candidate for the transplantation. This is, I talked about the early and late engraftment phase. I will show you the graphs of the efficacy, just because of the time I want to. Sorry. Okay, just let's see, go on with the visuals. If you look here, this Kaplan-Meier, as the curve goes down, the percentage of patients drop in terms of progression-free of survival. So if you look, we divide them below 40 and below 5 years of disease activity. So which one did the best is when you transplant the blue curve, which is below 40 and below 5 years from the diagnosis. So the earlier, the better. And compared the lowest, there is still improvement, but it is lower in patients with more than 40 and more than 5 years of diagnosis. So you remember my initial concept about the disease, the earlier always the better. And nowadays we started to have more and more enrollment in patients. The immune system after the transplant, you get like a brand new immune system, and hopefully you don't get the memory B cells, which we think is really the one causing the autoreactive cell to cause the inflammation. So in the new immune system will not have the memory B cells that are specific to activate the T cell to cause the inflammation and the neurodegenerations. So there are really challenges in the treatment in patients with stem cell transplant. It's really high cost and it really requires, it's only can be done in highly specialized centers. And it's really, you need a big help from the hematology expert. It doesn't come without complications. There is really risk of infection and patients can die. So it's patients even can die from just thrombocytopenia, like a simple fall can cause massive bleeding. So the American American Society Board of Bone Marrow Transplantations, they like revised the criteria. They used to say patients only with they defined the criteria to include patients if they have an EDSS of less than 6, but really, even regardless of the EDSS, if the patient is having active disease or highly active disease, even if they have high EDSS, they still can be a candidate to go for the transplant. There are many ongoing trials. I want to highlight that most of the evidence is coming from observational studies. We have very limited evidence. It's required a lot of logistics, and it's really what's really competing with these studies is the highly efficacy therapy. So, in conclusions, the efficacy is really proven, especially in patients with aggressive MS. All that it does is just reset the immune system and can result in really very long-term remissions. Safety is very important and crucial. It's the earlier the better, and what is the key for the success is the patient selections. You really need to select patients carefully, and if you have any patients, we are happy to take over. And if you think any patient is a candidate, just feel free to transfer the patients. All what we need is just a medical report and the Saudi national ID, and they can log into the website, or you can communicate with me directly. We accept any Saudi patients who are candidate for transplant. And with that, I'd like to thank you for your attention.
Thank you so much. Please join us. Please. Thank you so much for your attractive and informative lecture. We're going to open the Q&A part of session for this lecture. If there is any question from the audience about using stem cell in multiple sclerosis. Yeah, we'll take one question. Right. ما شاء الله في إطلاع طيب من الدكتور ماجد.
السلام عليكم. الدكتور الدكتور من المحاضرة أكثر وضعها مثرية صراحة. في سؤال بس بالنسبة للسelection criteria for patient to go for stem cell transplant and الحرص. هل تعتمد على الage وال diagnosing time ولا تعتمد برضو على activity of the disease itself? And is it blind in specific type of MS, latching limiting, blind or progressive, or all subtypes of MS?
Currently, we have our local criteria, which is the age below 45 and this is below 6. But we can overcome the criteria if we think that the transplant might help the patients. The most important is any patients who fail like high efficacy therapy is immediately a candidate. So you see patients with high efficacy therapy and then they fail therapy, he's an immediate candidate. Or if patients like even untreated and who develop like 2 relapses still within 1 year. Like we see these kind of patients. Luckily, it's not a lot, but you see patients who you counsel and you decide to start them treatment, and then just like we want to see him after 2 weeks or 3 weeks, and then he develops another relapse. These kind of patients were highly aggressive. Really prompt referral can really change this patient's life. We need to have early treatment, please. So if you suspect any patients, refer from early on.
Thank you, Dr. Regarding this lecture, it was very informative. I just have one question regarding the success rate in your center regarding this.
So I did not bring the data. We were in the phase of publishing soon, but we have really very good result. So far, we don't have big cohort because we are really selective. All of the patients of DMTs, like for 5 years, 6 years. Some of the patients, they stabilized or they had very minor increase in their EDSS for a short period of time, and then they stabilize. We have patients with EDSS improvement. That's really good, on maybe 20% or 25%. So EDSS improvement, this is something that we don't usually see with our standard treatment. I think in the future we should consider this treatment for the progressive cases. It's still, the evidence is weak, but I think there is a hope in the future to treat these kind of patients.
Yeah, Dr. Ahmed, let's simplify the issue. Can you tell us briefly about the sort of experience in the stem cell field and using stem cell with treating the MS? How many patients you had participated in this program? How many centers briefly?
We have, as I said, at least we have a small cohort, but I believe we are the largest in the kingdom, so we have 20 plus cases. We started even to treat other neuroinflammatory in our center, where patients failing some treatment like neurobiology, suicide. When we stuck, we transplant.
So, which type of stem cell you are using in your center?
So we use hematopoietic stem cell and we use myeloablative. By the way, there is also some new, you hear about mesenchymal stem cell transfer. Mesenchymal cell is different, it's not hematopoietic stem cell. You know, the difference is mesenchymal cells are not hematopoietic, so it can generate any body tissue. So it's mainly hoping to treat what's happening. Remember the field in MS, we have the neuroinflammation, we have the neurodegeneration, and we have the remyelination. We're only doing good in the inflammation part. These two parts are still, we're way behind.
So thank you so much, Dr. Ahmed. Let's proceed to the last session. So let's introduce standing the last session. Nursing has a role, and an important role, to treating patients with multiple sclerosis, and in order of that role, we are pleased to proceed with introduce the next guest speaker, Dr. Fatima Al-Amoudi. Dr. Fatima, she is an assistant professor in medical and surgical nursing in the Prince Sultan Military College of Health Science Tehran, and chairman of the Committee of Nursing Training Department. She had a PhD in nursing from University of Florida, United States of America. She had a long experience with nursing, especially with MS patients. Please, Dr. Fatma, the floor is yours.
Assalamu alaikum. First, I want to thank Arafat for inviting me for this session, and it was very interesting from you for the stem transplantation, for the AI. Okay, because we are as nurses, we just hear from the perspective of the nursing, not perspective of the doctor, and not about how to diagnose the disease. Okay, this is your profession. So what nurses need to know about this disease? I will just pass from this. Okay, we'll go first about the definition of the. Okay, for the definition of the multiple sclerosis, it is an autoimmune disease, meaning the immune system is attacking our body, attacking mainly the neurons, and it disrupt the myelin, which is protect our axons. Okay, and that will cause, of course, clots, and it will interrupt the transmission of the electrical activities throughout the CNS, central nervous system. in Saudi Arabia. The prevalence of this disease is about 62 cases per 100,000 Saudi population. As you can see here, the normal neurons and the demyelination neurons, that there are some blocks or some places it has destruction in the myelin sheaths. And of course, that will lead for a variety of manifestation. Why? Because it depends on the neuron itself that's being affected. Is this neuron responsible for the speech? Is it responsible for vision? It depends on the base of the neuron. As I mentioned here, it appears that there are some blocks in the myelin sheaths, okay? And that usually these blocks are scattered through the CNS. And they are multiple, they are not only one or two, as I think Dr. Ahmed showed that in the MRI picture, there are multiple blocks. There are many causes for this disease, but actually it is the main thing that it's unknown. It might be autoimmune for some triggers, such as some infections or viruses. And there are some other research show that there are some connection between the vitamin D deficiency and some races like the white races or the female have more multiple sclerosis. Okay, for the manifestation, it usually is varied. As I mentioned, it depends on the neuron that has been affected. And the main or the more common symptoms are fatigue, numbness, tingling, weakness. The patient usually have elimination problems in the bladder and in the bowel. Sometimes the patient will have constipation, sometimes the patient have diarrhea, sometimes the patient have urine incontinence, and sometimes are urine retention. Depending on what exactly being affected, okay? And if this electrical activity, the amount of the electrical activities that being affected. Here you can see a lot of clinical manifestations such as vertigo, sleep disturbance, double vision. And when we go for the classification of the disease, there are 4 classifications. Most of the cases, I can tell maybe like 85% from the cases going under the relapsing remitting multiple sclerosis, it usually starts with the relapse period where the symptoms become worse, and then after that, it followed by a period of remitting, that the symptoms are disappeared. Okay? After that, actually before the primary progressive, I can say that secondary progressive is a type from the relapsing remitting multiple sclerosis. But what happened here, after a period of time from relapsing and remitting, the symptoms start to become continuous, progress for the lifelong. The third type is primary progressive, where the symptoms start, and usually there is no relapsing period. Most of the time it starts and it continues. And the last type is progressive relapsing, where exactly it's connected to the primary progressive, but after that there are some period of relapsing. Okay, for the diagnostic procedure, usually, as we know that they might take some lumbar puncture to make sure or to rule out and to find some proteins that indicate the inflammation. Sometimes they will go for evoked potential test, so they will apply some electrodes in the scalp of the patient and in other body area, and then they will stimulate the nervous system with like sounds or noise or something to just measure the electrical activity. And they will not just only measure the electrical activity, but they will see also the speed of these electrical activities. Here you can see the MRI has many blocks. This is the treatment, okay, and the treatment is basically not under our job as a nurses, it's under the physician, but most of the time we use beta interferons And this usually puts the patient at risk of getting infection because it reduces the immune system function. And the corticosteroid, and sometimes we give them some treatment for the signs and symptoms. Okay, for the nursing management, which is I want to speak about it and focus more. Okay, we are as nurses, we don't write the order to diagnose the patient, and we don't write the order for lab. We are not the one that's giving the medication for the patient, but we help and reduce the severity of the signs and symptoms of the patient. For example, our patient has constipation or have diarrhea. If the patient has constipation, we must give him some educational therapy to about how to reduce the constipation severity. You can take food software, eat high fiber diets, drink plenty of water. If they have, for example, some other issues like cognitive problems, we might send them referral for the cognitive therapy or speech therapy. We should also give some emotional support for the patient because those patients usually they have this disease and they know that within 15 years they will be disabled. Not all of them, almost 30% from the cases. Usually also we need to provide safety measures and teach the patient how to use the safety measures. Why? Our children have a problem with the vision. Most of the time they see some dark spots, okay, and have blurred vision. So we have to teach them how to scan the environment before going from the leg to the floor. Our patient also has a problem with the coordination, so we have to provide some safety measures for them, especially, for example, during taking shower or bath. With physical mobility, our patient has fatigue, has weakness, but we have to ask them to go to do some exercise, not in a hot weather. The patient usually, the signs and symptoms usually become more worse with the hot weather. So we have to ask them to do exercise, but not in a hot weather. The best thing recommended for these patients are this one. Provide assistive devices, especially at shower. And so most of the research for the nurses focus more in how to reduce the severity of the disease and how to provide emotional support for the patient and the families. Okay? Thank you.
Thank you so much, Dr. Fatima, for your brief lecture. And it was focusing to the nursing room. Please join us. So we're gonna open the Q&A session for a brief time before we're going to honor the speakers. Dr. Fatima, we received a question. Nowadays, there is a new combination like new natalizumab injectable medication. It's dependent on educate nursing more to instruct the patient how to take the medication. And you are one of the training member in your college. Do you have routine sessions or routine courses to improve the quality of care for the nursing? Are you working with some centers or some hospitals to give physical sessions to deal with the new medication or not?
For in our college, we have some like they usually go for the clinical training before go to the hospital. One of the things is them how to educate the patient. Okay, so usually in the exams we provide for them. We usually ask about this, how we going to educate the patient about even the medication. Not only this, even in the theory part, we must provide them with a lot of simulation questions to assess their cognitive abilities and knowledge about, for example, the beta interferon. Okay, what are your patient receiving this medication for a long time? What do you expect? And what are you going to do with the patient? How are you going to educate this patient? So we are training them well before sending them to the hospital. So whenever they face this type of patient, at least they know how to educate the patient.
postgraduate. So I'm doing some sessions for the employee people to improve their quality of practice, or just focusing on students during the internship or the student age.
Yeah, for postgraduate, we are planning to have a master's degree in child or college. So of course, one of the things we did about multiple sclerosis. From my own experience, I didn't meet any patient with multiple sclerosis, honestly, because it's almost like 62 cases per 100,000 patients. But yes, I'm sure that we will start to teach them more and more.
Thank you so much, Dr. Fatima, to be with us tonight. At the end, we are requesting Ms. Rima to honor the speakers to go into the last chapter of our session tonight. We'll start with our remaining speakers because we have another lecture of Dr. Anas Al-Haylan running now. So we'll start with Dr. Majid Al-Abdili. Please, Dr. Majid Al-Abdili, proceed to capturing a picture. Thank you so much for your attending and for your participation in our night. Thank you so much, Dr. Majid. Dr. Mustafa, kindly proceed to the floor. We are very glad to have you tonight. Thank you so much, Dr. Mustafa. Our last speaker, Dr. Fatima, please proceed. Thank you so much to be part of our partnership to treating the MS patient. Thank you so much. So at the end, dear distinguished attendees, thank you so much for attending our scientific committee or meeting tonight, and hope to meet you in the upcoming events. Thank you so much, and assalamu alaikum wa rahmatullahi wa barakatuh.
حابين نشكر الدكتور محمد طبعا على الجهود المبذولة في هذا المعرض، فتتحق بعد الدكتور.
جميعا. في معرض مصاحب اذا حابين تزورونه، وفي المعرض الفني